just to kind of contextualize what we're going to talk about, I think that when we were looking at the planning for this year's NOC, we went back to look back at what we discussed at the NOC last year. And it became completely clear that whilst we were talking about a lot of work that needed to be done and we were really getting involved in the types of work we could become involved in, nobody could have predicted what 2020 was going to look like and the challenges and issues that we were all collectively going to have to deal with in both initially come to terms with the pandemic and then going through a management process, which has now gone on for a significant significant period of time, and through a number of various either national lockdown or restrictions, and also obviously we need to be aware that outside the national ones there have been regional ones. So the aim of tonight's session is very much to consider this and to look both at the response to the pandemic across the sector, and also to start to consider about where maybe we're going to be going in the future. I think it's really timely actually that we're talking about this tonight, having had the announcements about the revised tier structures across the country, certainly the announcements around Christmas, but also we're standing kind of on the cusp of a potential vaccine or potential vaccines that probably for the first time, certainly for the last 6 months, have given us a hint of a light at the end of the tunnel. So, as I said last night, I think what we need to do is we need to be very proud of our response to this, and really that's tribute to all of you that are on this call tonight and have been involved in maintaining the delivery of urgent emergent services and site testing services as we've gone forward. I think it's been noticed, and certainly from my perspective, and I'm sure everybody in the panel, we're really aware of the pressures and the stresses that everybody has been under, and we've tried, and I hope we've been able to support in the best way that we can. But we also, as I said last night, need to recognise it's taken a toll on everybody, both personally and within business. And I don't think there's anybody anywhere that won't know somebody who's been affected by COVID in some way. So, as I said, moving to tonight's session, what we have is we have a panel tonight from across a range of sector bodies, and they are here both to outline the work that they've done and also to take questions and discuss where we may be going in the future. So if I could ask the panelists to turn their cameras on, and I would like to initially hand over to Leslie Longstone.
Thank you, Richard, and for the opportunity to talk to you all tonight about our response to COVID-19. I think first of all, first thing to say is that we saw our primary concern in with the onset of COVID as being to protect the public, which is what our primary concern is all of the time. But we also recognised that we would keep the public safe if we kept our registrants safe as well. And so for us, what we did fairly early on is issued a statement which was about actually what we need to do first and foremost is trust in the judgment of our registrants. We knew that our standards and even the law to some extent wouldn't actually keep patients safe in the pandemic, because they were written for a situation that nobody had envisaged. And we didn't want that to get in the way of registrants actually doing the right thing. That was the most important thing for us. How do we enable registrants to do the right thing in order to protect themselves and to protect the public? So we issued our first statement, which essentially said, please do use your professional judgment. And when you use your professional judgment, where you do properly risk assess and you take decisions in the best interest of the patient, even if they turn out to be wrong, we will support you. We're not going out to catch people. We want to support you in order to take the professional judgments and assess the risks in the way that you need to. And then what we did was we followed it with a series of more detailed statements, which kind of picked up on particular questions that we were being asked at the time. In parallel, we carried on with all of our operational work. GRC didn't furlough any staff. The registration process continued. We were nearly at the end of it anyway, so that wasn't too bad. We had a few people who decided they had registered, had paid, but decided they weren't going to work after all, so we had to deal with those. I think probably one of the most significant things we did is to make some temporary amendments to our education requirements in order to facilitate the changes that were happening within our education institutions. We also had to completely revisit our fitness to practice processes. So we moved from face-to-face hearings, which obviously couldn't happen, to remote hearings almost overnight, and have managed to, not every single fitness practice case, but the vast majority of them have proceeded as they have needed to. Sort of where we are now, we are consulting on the statements that we issued during the pandemic. We consulted on linking them to the college's red, amber, green system to try and make that simpler and to enable people to plan more effectively. And we that closes in January, and we'll decide then how that linkage is going to happen, and indeed if there's anything in there that people feel ought to be made permanent, because there may be lessons that we've learned through this process. The other thing going forward for us is the most significant issue is the education strategic review, and how we make sure that our proposals for education are fit for purpose in the context of what is a new world post-COVID, and in particular increased clinical practice, more integrated provision with other primary care providers and indeed secondary care as well. So I think on that basis, other than to say that throughout we have worked really closely with other partners on this call, and will continue to do so. But I think that's enough for me. And I'm going to hand over to Debbie. Debbie McGinn.
Thank you, Leslie, and good evening, everyone. My name is Debbie McGill. I'm Head of Policy and Public Affairs for the Association of British Dispensing Opticians. So our priorities when COVID struck was to work with all representative bodies throughout the UK to maintain service delivery as safely as we could for our members and patients, to continue to deliver the care that we needed to maintain throughout the process. And that included working with everyone on providing our members with advice and guidance on increased infection prevention control, PPE, social distancing, all public health advice, and in turn also to support members who couldn't deliver services, be it practice owners, staff within who were in the clinically vulnerable groups. And that led us to having discussions again throughout the UK on financial support packages and in relation to delivering GOS services. And then there was the providing all members with advice and guidance on national schemes set up by governments, like the furlough scheme, the self-employed support, etc. And there was a time where we were looking with the GOC on workforce deployment throughout other parts of the NHS, where we thought it may be required. So we were working hard on that. And yeah, without getting into the detail anymore on everything there, we also had two other priorities, which were, since ABDO are the awarding body, we had exams planned throughout the summer. So we had to make arrangements to make sure that they could be delivered safely, and for individuals that couldn't, again in the clinically vulnerable groups, if they couldn't attend for exams, we've made arrangements for them to sit them at a future date, and also continue to deliver CET remotely throughout the period, which we've done quite successfully. So I think that's as much as I can say it without stealing any more time for others to have their say. So I'll now pass you on to Zoe. Thank you.
Thanks, Debbie. So I'm Zoe Richmond. I'm the Clinical Director in interim role for the LOC Support Unit. And I think one of our key priorities really was to make sure that the LOCs and the people, the contractors and performers that they represent, had the support and knew where to find the guidance. So we worked very closely with all the organisations represented this evening to make sure that everybody had that consistency of message and knew where to find the most appropriate advice at the right time. As an organisation, we also supported LOCs by providing a levy freeze. We performed our own financial review to make sure that our own business could continue on our reduced income, but also support needed to make sure that LOCs could continue their business and support their members on the reduced income with loss of GOS activity. We strengthened this as well by holding some treasurers sessions, delivering hands-on support to the LOC treasurers, and really stepped up our engagement with LOCs and their members on the whole. This really started, last year, on the back of the NOC last year, and I think LOCs were in a very good position as we came into this pandemic, which we'd already actually established LOC forums sitting on the NHS regional footprints. So we had 3 of the 7 planned forums already functional, and we very quickly developed groups of LOCs on the other 4 in the other 4 NHS regions and created discussion forums, and that brought the LOCs together on that regional footprint on a very regular basis, weekly, and we facilitated those conversations, made sure that they had an opportunity to ask questions and of lots of the optical leads and signposting them to where the guidance is, and that was backed up by more communication through the WhatsApp groups, the LOCSU website signposting to the guidance. We supported members with access to NHS mail and PPE. I don't need to remind anybody dialing into this webinar around the uncertainty around PPE in the early days and what challenges it created for optical practices. And certainly LOCSU supported, but with everybody, worked very hard to secure a sustainable supply and an NHS supply at no cost. But in the meantime, LOCSU worked with Primary Care Services and created a PPE shop, and that ensured that there was a low-cost, sustainable supply of PPE for optical practices. But I think one of our the most important things that we've done, and I would say this because I was very much involved in this, was ensure that every optical practice had the opportunity to deliver urgent care to their populations through the Qs service. So I now want to leave it there and hand over to Harjit.
Thank you, Zoe, and thank you everybody for joining us this evening. I'm Harjit Sandhu, Managing Director at FODO, the Association for Eye Care Providers across the UK. I'll keep this brief because having worked with colleagues on the panel today throughout the pandemic, there'll be a lot of overlap. So colleagues will pick up on other details, I'm sure. So on our response, look, we all started off with lots of unknowns. About 9 months ago, public health agencies were getting to grips with how this virus was transmitted. Furlough did not exist, and the country was in lockdown. So our initial phase really meant crisis mode. We analysed large volumes of data and information with scenario planning and got members guidance as quickly as possible so that they can make informed decisions about what to do next, and which we did in partnership with colleagues on the call. So in addition to this, we've worked closely with NHS and sector bodies. And on this, I would like to say, because it's quite difficult within any sector to always know what's happening outside of our own sectors. And as policy wonks, we have looked at every single other healthcare sector. What are they doing? And I can genuinely say we should be really proud of the optical sector at all levels, with the way the bodies have come together, with the way the professions responded, and the way the providers have really been there to meet needs and work through what are very, very difficult challenges. So I think, we've led on all levels, including on influencing and leading on gender. And talking about that, building on that, FODO, along with ABDO and the AOP as part of the OFNC, and a close group of us have worked long hours, Peter, Debbie and other colleagues, to make sure that we've constructively worked with NHS England throughout the pandemic to ensure practices had the support they needed. Now, there have been delays in communication within the commissioning system, somewhat out of our control, but I hope everybody on this call is pleased with what we've managed to achieve. So this joint working across the entire sector, I think has been a massive positive in all the chaos and uncertainty that everybody's been living through. And I hope it's something that doesn't go away as we start to build on next steps. So briefly then on looking forward, what we're focusing on at the moment is vaccines, the economic impacts of the virus and the impact on clinical care. So briefly on those, on vaccines, we're looking at everything from logistics to timeliness and how we collectively ensure primary eye care is at the forefront in the first rollout. On economic impacts, we're thinking now about the long-term impacts on the sector with unemployment, etc., expected to rise. And on the long waits, and the most important for all of us, is with hospital sector colleagues struggling to meet need, what we can do collectively, working together across LOCSU and all the other sector bodies, really to meet the backlog of patients so we can prevent avoidable sight loss. So that's it from me. Peter, over to you.
Thanks, Harjit. I'm Peter Hampson from the AOP Clinical Director. So the problem with going a bit further on in the list of people is people say what you're going to say. So it gets a little bit difficult to know what to say. Obviously, most of what everybody else has said is true. I think the initial phase was we were working on guidance that normally when people ask questions of us, we know roughly what the answers are going to be. And they need tailoring to the, the specifics. But broadly, we know where we're going to sit with things. The first phase of this entailed really developing new guidance from scratch, researching it, writing it, which involved the long hours. And sometimes I know people wanted answers quicker than they got them, but there really weren't answers at some points, and people worked incredibly hard to try and provide those as quickly as they could. From an AOP perspective, our focus was on the members. So, I mean, the team, and it really is important to stress it's a team effort. Lots of the AOP team worked incredibly long hours, answering member queries. We saw thousands upon thousands of member queries. And it's important to stress that it's not just the people like me you see sat on a screen at points or names that you recognize. It's the people that publish things for the web. It's people that get things out in comms. It's people that handle the membership and all sorts of things. It's incredibly, it's an incredibly collaborative effort to put all of that together. As Harjit and Debbie have said, we've worked very long hours with NHS England, trying to secure PPE, trying to secure funding, trying to make sure that practices can survive and try and come back from this. And that's going to be a big part of our focus as well going forwards. And that ties into the webinar that some of us were on last night about national outpatient transformation as well. Because obviously going forwards, what we need to look at is what roles optometrists can take up, where we can utilize our skills fully. And also for our colleagues, dispensing opticians who also have a role to fulfill in these new ways of working, because there are these huge backlogs in secondary care. And we are very, very well placed to actually help with that, which helps professional development, but also helps people avoid sight loss. I don't think I've got an awful lot more to say than that because of what's gone before me. So I'm going to hand over to Daniel, and hopefully, Daniel, I've left you some things to say, and I've not said all of them already.
Peter, thank you very much. I don't think there's much left to say, but my name's Daniel Hardman-McCartney. I'm clinical advisor for the College of Optometrists, and I really would like to reiterate, I think, what Richard and Harjit and Peter has said already, that, I've never been prouder to be an optometrist. The way that optometrists on the ground have delivered eye care through really adverse conditions, the way we've completely adapted everything we do, the way the sector's come together to really focus on the public and saving sight and doing it safely at the same time. And I think actually as a profession, as a really important pillar of primary care, we're in a really good position now, a stronger position perhaps than we were a year ago, to work with our colleagues, in general practice, in dental and pharmacy, in an important healthcare function going forwards. But to the point in hand, the COVID response, the college team, along with everyone else here, started working on this back in February, 9 months ago. And our aims were keeping practitioners and practice teams safe, keeping the public safe, keeping eye care open, to ensure that the raison d'etre of optometrists and eye care, saving sight and keeping people seeing clearly, could be maintained whenever possible throughout. And we did this through guidance, taking a scientific and collaborative approach, working with our fellow other colleagues. We had early conversations with the Royal College's general practitioners, dentists, pharmacists, so we really understood what was going on, and to ensure that we understood what was happening and how we could best inform optometrists on what to do and how to do it safely. With regards to policy and influencing, very early on we were writing collective letters, lobbying NHS England, Public Health England, PPE, access to NHS Net, and a lot of work by everyone here behind the scenes, as everyone said, late at night, to set things in motion to ensure that optometrists were represented, our voice was heard, and we could deliver what we deliver best, eye care. The college tried to produce as many tools as possible to enable practitioners and practices, from simple things like posters to vision testing charts, just resources, materials, education, as much as possible. Sometimes I'm sure it felt overwhelming how much was coming out from all of us together, and really collaborative pieces as well early on, working with FODO, AOP, GOC to ensure contact lens delivery to go ahead through virtual templates for dispensing for contact lenses, letting practitioners know how they could really make the most out of the easements that the GOC put in place at an early phase. Representing optometry to NHS England, ensuring that we weren't forgotten, and education as well. So the college is a big team, like Peter mentioned, the AOP is a big team, and there's many people working really hard behind the scenes, not just the few names that you often see. Our education team were working tirelessly throughout to ensure exams go ahead, both that they were safe for the examiners, safe for the students, and also they kept the high standards to ensure that people passed and it remained a solid, respectable qualification. And that created a lot of challenges and difficulties to get it right. But they've done that. So the scheme for registration has gone ahead, IP exams have gone ahead. So lots going on there. I think I'll end there. So if I pass back to Richard, and thank you.
Thank you, Daniel, and thank you to all of you for your introductions. I think that shows that we have a wealth of knowledge on the panel, but also everybody's been involved, everyone's worked in collaboration, but obviously within their own bodies as well. I should have said in my introduction, we're going to go into the question and answer session now. On the bottom of your screens, you'll see there's a Q&A box, and some of you already have found that. Feel free to submit any questions into that box, and whilst I may not be able to ask them specifically, I'll certainly try and get as many of those answered as we go through. So the first question, we've had some submitted in advance. So the first question, which I'm going to ask Daniel to comment on, was in the first lockdown, services were restricted to urgent and emergency. In the second lockdown, there's been a different approach. Why is that?
Yeah, great question, and it is curious. So if we cast our minds back to March, we issued a statement, I think towards the end of March, that practices should only offer urgent and emergency care, so to pull back from routine care, and that was later on supported by NHS England. And we did that because we're in a situation where a lot of practices didn't have access to PPE, we didn't have the training in place to know how to use it. There was a lot about COVID that we didn't really understand in terms of the transmission, and the public were being asked to stay in their households and not go out, and the whole of society as we know it was restricted. And so it seemed absolutely proper to postpone people's routine eye care so we could prioritize essential and urgent care. Towards the end of lockdown, the ONFC very helpfully widened the definition of what essential mean to ensure as many people get the most of it as possible. And that's where we were at the time. We really needed to pull back, take a precautionary principle, and ensure safety and priority to those who most needed eye care. However, now during the second lockdown, we're in a very different situation. We have the training in place, we have the PPE in place, we have the infection control procedures in place to deliver eye care. And we know that during the first lockdown period, in all disciplines, not just optometry and ophthalmology, that there's a lot of non-COVID related health problems that were affected. People didn't access GP services who needed to. People weren't referred for the same number of retinal detachments that would normally happen. People weren't coming forward. People were sat in care homes scared to access services or domiciliary appointments when they had symptoms that could be indicative of wet macular degeneration. And therefore, because we had all that learning in place, we could continue to offer services beyond just urgent and essential, but routine services as well. Because actually it's really important to remember that a routine sight test is a really important health function. It detects asymptomatic disease. It enables people to see more clearly. And it wouldn't be right to postpone that. We'd be doing a disservice to the public if we said, oh, actually, we're not going to offer any routine eye care for the next 6 months or year, or however long this may be, until we reach some kind of endpoint. So the approach by the government, by NHS England, and that we fully support, is that in the second lockdown, that the practices are well equipped, it's safe to offer eye care, and therefore we should be offering all aspects of eye care from routine to urgent and essential.
Brilliant. Thank you, Daniel. And Leslie, have you got any comments on that from the GOC perspective?
I mean, I just support everything that Daniel said. For us, it was about balance of risks, risk of people's eye conditions going unnoticed because they weren't having their eye test, but set against the risk of bringing people into practices. And at that time, we couldn't even measure that risk because, as Daniel said, we didn't have information. We just knew that it was very risky. And actually, we were, at the time that statement was issued, the groups on this call were all in discussion together, and we had statements from other nations of the UK, but not from NHS England, and it seemed pretty inevitable to us, and from the conversations that were happening behind the scenes, that was the direction of travel. And we were, registrants were crying out for advice on that particular point. So we decided between us all that that's what we would, those are the statements that we issued. So the college took the decision that it took, we issued a statement in support, saying that we endorse that view, and completely agree again that we reached a tipping point along this journey, whereby we got to a stage where we understood the risks. We had various risk mitigation strategies through PPE and social distancing, etc. And the balance flipped. Then at that point, the risks associated with not seeing people started to outweigh the risks of seeing them, and therefore that's why we're open today.
Thank you, Leslie. I'm going to move on to another question. Just before I do, I can see on the questions, there's a couple of people that have asked questions about vaccines, and we've got a number of questions submitted in advance about vaccine, which I am going to get to during the course of the session. But what I really want to do now is, one of the questions that's come in this evening has talked about the initial response to the pandemic and the fact there was a replication of information. And I think actually the final sentences of that question sum it up very well, which is to say, at the beginning, to the outside, maybe it didn't seem that collaborative. And what have the sector bodies learnt for the future? So Harjit, if I can go to you first, have you got anything? What would your comment be on that?
Sure, I think it's a really good question. I think, again, there's two things here. First of all, what was actually happening behind the scenes, as it were. Straight away, I remember this quite clearly. We were trying to coordinate ourselves because everything was changing so quickly, and we had said the college should have their FAQs for clinical questions. ABDO will have the clinical questions for dispensing, and we'll signpost to those. So if you look at all the correspondence from us, it was very much signposted to sector bodies. In addition to this, we did initially remember, we do have slightly different audiences for our readership, and they have different needs to some extent. So we had to get the information out quite quickly so people could orientate themselves. As the pandemic came in and we got into our own pattern of working, you can see that the sector response has been ever more coordinated because time has allowed that, the bandwidth has allowed that. But the intention very much has been, let's not take up the bandwidth of the sector with reading the same thing effectively 3 times, 4 times, written slightly differently. We used to obviously have the Optical Confederation that we communicated via, and we do have to look at how we can get the communication to where it's needed effectively going forward.
Thank you, Harjit. Debbie, have you got anything you want to add to that at all?
Did you ask a different question, Richard? Because my screen just completely went blank.
Sorry, Debbie. I was just asking if you had anything you wanted to add to Harjit's response at all.
No, I think he's covered it well. Yeah. So no, I'm happy with that.
Okay. And going to one of the questions, I guess, Daniel, this links almost to one of the things you were talking about. I mean, the question's been framed in terms of ghost clinics, which I don't really want to go to specifically, but I think there's a broader question here, which is about what sort of support is there for practitioners who maybe don't feel safe practicing? I don't know whether or not that's something you want to go for, Daniel, or Leslie first. I'll go to Daniel.
Yeah, happy to start on that. And where there's been such a rapid rate of change in practice, both in how we deliver the site test and how we manage clinics and how we see patients, often practices, the normal checks and balances and scrutiny hasn't been in place that we'd normally expect in a normal time. And that means practitioners have been, working in adverse conditions as normal, but some practitioners feel that actually, patient care is compromised or patient safety may be compromised. And we've been very clear, along with the AOP and the other stakeholders all here, that if anyone feels that actually that balance has tipped, so they're in a position where, that they're being asked to perform the unreasonable or patient safety is at risk, it's very important that they raise a concern through the channels that are in place. And actually, as a registrant, as a healthcare professional, it is your responsibility. You have a duty to your patients and to the rest of the profession to actually raise those concerns in the appropriate manner. And that would be following the speaking up procedure in your practice. In the first instance, calling it out to your practice manager or your practice owner and saying, look, I have a concern here for X, Y, Z reasons. And that practice manager has a responsibility as a business registrant or as a clinician themselves to take that seriously and to investigate it. And if the registrant feels that that's not being heard properly, they should escalate it through the procedure in the practice. If it's a big company, that might be to their professional services team, that may be to their head office, their occupational health team. They can speak to myself or my colleague Paradeep on the clinical advice line, or our colleagues Peter and his team at the AOP for advice about how to escalate that, how to communicate their concerns effectively, so they can be handled as quickly and as appropriately as possible to put their own well-being first and also patient safety first. And I've received calls from people who do have concerns, and we've supported them to raise those concerns through the right channels with the companies where there's concern, to try and address those issues. But very specifically, ghost clinics is a weird term. It means different things to different people. It's not really a defined term. But whenever someone's not given enough time to give patients the care they need, or are expected to work through their lunch breaks or late after work, there is clearly a concern and a management systematic issue that needs to be addressed. And our experience has been that where people raise concerns through the correct channels, actually the professional services teams and the head offices are very keen to address those issues and to put them right, and to get their house in order, and for it not to become a big issue. So if anyone listening to this does have concerns, then I would say feel free to contact us on the clinical advice line. But the thing to do is to follow the internal procedures that you have in place to raise that concern. And where there has been such a movement of change over the last year, that there may be some individual practice managers or individual cases where things have not been right and the pendulum swung. And in those situations, it's absolutely essential that clinicians grab on the reins and pull that back in and follow their responsibility as a clinician to raise that concern.
Thanks, Daniel. I'm just going to move us on to another question, which I think is a really good question. I'm going to ask Peter. I'll come back to him in a minute. So I'm going to ask Peter just to comment on this one. Do you think that the pandemic has changed the public's views to the profession beyond just being sellers of spectacles?
Wow. Okay, that's a question, isn't it? I hope so. I like to think it didn't need changing that much, but I suspect it has. I think the initial access to urgent and emergency care was crucial, and that really embedded that we weren't just there selling spectacles, because that was actually the last thing that we were doing. It was treating people with problems, and that was the only place realistically you could go and get seen or be seen remotely, because the hospitals just did not have capacity. So I'd like to think so, but I'd like to think that people were already fairly aware that we aren't just sellers of spectacles, or I don't think any of my clinician colleagues would think that we are. So hopefully it has elevated the profession, but hopefully it was from a fairly high baseline to begin with.
Zoe.
Yeah, just to add to what Peter said there, I think without a doubt, there's been a change. We've seen a change when we're sitting, in local stakeholder meetings with colleagues from hospitals that are really working very proactively now with primary care to understand actually how can we work better together. They recognise that actually there's a role for primary care to do much more work in an integrated way to support them to meet their backlogs, and that really has changed in the last few months. I would like to think that we definitely had across England pockets of excellence where it was already working, but I think that's spreading out there now. And I think the adoption of queues in some of the areas that we've been trying to promote minor eye conditions type services for many years, and they've picked up on queues, and that really has developed a different behaviour between clinical colleagues.
Thank you, Zoe. Debbie, I'll come to you in 1 second. Can I just go back to one question? Leslie, you just wanted to make a comment on raising concerns?
I did. I just want to say I've noticed that as well as the question about ghost clinics, there is a question about other case-specific issues in the Q&A. And obviously, I hope people will understand that I cannot talk about specific cases. But what I will say, if I go right back to the beginning about the statement that we issued at the beginning when we said, use your professional judgment. We know you're not going to be able to abide by all the rules because of COVID in effect. But you need to do so from the point of view of risk assessment and with the best of intention to protect the public, and then we will support you. We never said we would support people who were not starting from that position and were not taking decisions that were in the best interests of the public. So when these concerns are raised with us, and I agree with what Daniel said, that it's a good place to start within your organisation, raise concerns. The vast majority of things can be resolved at that level. They can't always be resolved at that level. And if it's appropriate to make a referral to the GOC, then you should do so. And they will be considered in exactly the same way as we consider cases ordinarily. Some of the cases that have been raised with us, we have not taken any further, and others we have. As is always the case, it depends on the particular circumstances and evidence in the cases concerned. But we are going to be issuing or consulting on new raising concerns guidance within the next few weeks, which hopefully will be a good reminder for people as to what the different options are in terms of escalation. If you can get them resolved internally, great. But if not, and you are really concerned about public safety, then there are other routes, including to, but not exclusively, but including to the GOC. But please do that directly and not on Twitter or on any campaign websites, because we miss them. We don't pick them up in that way. Please write to us directly if you've got a concern.
I think it's something that we can all support. Debbie, you want to say something?
It was just really to add to what Zoe had said, that I think it's important to note here that at a higher level within the NHS, optical providers and practices have been recognised, I think, more so now as primary care providers and part of that team. So I think that's definitely a massive step forward, and hopefully we can build on that together going forward. So it's definitely something I think that needs to be acknowledged in England.
Yeah, I think it's probably a long time
coming.
Absolutely. So I'm going to move us on to another question. It's not linked, but it's something to do with the discussions with NHS England. So a question's come in from somebody who has a practice in Greater Manchester, and they're saying that they've struggled through severe restrictions and continue to struggle through severe restrictions, but are now likely to face issues as far as the business is concerned because of lower revenue, higher unemployment. They've used the term optometric deserts. Harjit, in terms of the discussion with NHS England, how do you think we could take that forward?
So the question goes on to talk about how, although there's enhanced schemes, practices might have closed anyway. I think there's a range of, the economic impacts of COVID, unfortunately, are probably yet to be felt in 2021, and all the economists are talking about this. there's first of all several levels of support already available. There's the furlough scheme that's been rolled over to reduce overheads and cash flow, help with cash flow. We have been pushed particularly hard by the OFNC to get extra support to practices, and therefore we had rolled over for as long as possible the grant scheme. And Peter and Debbie will know this. We were able to negotiate special assistance for those practices in the most deprived areas of the country. Now, there's also a special exemptions criteria for practices that are struggling, but those are quite clear criteria. So I would encourage the person who wrote that to look that up, see if they're eligible. Finally, we, in the OFNC FAQs and all the correspondence, we do say, look, feedback to AOP, ABDO, FODO or LOCSU, let us know what you're feeling on the ground, because the more we hear, the more we can fine tune our discussions with NHS England. You know, we're not out of this yet, unfortunately. You know, there's lots of good things happening. There's a vaccine, we have PPE, we have good infection prevention control. But as this question highlights, we're working in an economy that has its own challenges, and we want to preserve the primary care infrastructure. We want practices to remain open, and we want our workforce to stay well and healthy on all levels throughout. So feed that in, and we will pick it up with NHS England as well as a genuine sign of stress.
Brilliant.
Peter,
yeah, it's Peter.
I don't know if you want
to add.
Yeah, thank you. So there is, as Harjit quite rightly says, that there is support for certain practices in the top couple of deciles of deprivation going forwards, and those practices should have had a letter saying or inviting them to apply for the additional funding. There is also an exceptions process, again, as Harjit says, which you can make use of, which is important. I think it's also important to point out that we aren't unaware of the challenges, and I think, I mean, at the height of the pandemic, we were probably speaking to NHS England more than we were speaking to our families, and we continue to be in close dialogue with them. And we make these points. Obviously, there are challenges. It depends on, NHS England will be monitoring how busy practices appear to be. Now, if practices aren't busy, then that gives us a very good case to go to them and say, look, you need to put in place some more targeted support, and we will continue to do so. And we've done so even this week, just making a case of we need to be keeping a very close check on activity levels and how practices are doing, and that the sort of extra support that we put in place was based upon coming out of lockdown 1. It didn't really take any account of the fact that we'd got lockdown 2, and then this new tier of restrictions, and potentially, you know, further restrictions after Christmas, dependent upon what happens. So we will continue to make that case. But if practices are struggling, then the exceptions process is the way to go. If they think they can get some extra help, hopefully everybody's seen that on the OFNC FAQs as well.
Yeah, and I guess it's important to mention from an OFNC perspective that those discussions continue and are refined as things go forward. Moving to a slightly different subject, Zoe, a question about lockdown 1 and how the signposting for patients with eye conditions into practices took place. Specifically, was it left to either a national or local approach for that to happen?
Well, it was a real challenge, wasn't it? Because what we ideally would have liked to have done is have a national approach, but we don't have a national solution. And so it very much ended up being a local approach, so that, you know, whilst we'd ideally wanted, when we implemented queues, to have a national solution so every optical practice could meet the needs, the urgent eye care needs for their local populations, and that was happening without a commission framework in some areas. What we couldn't do is support the redirection of patients through to optical practice without a commission framework that allowed optical practices to deliver this care. That's what queues was about. When we went into lockdown, around 60% of CCGs had commissioned a minor eye condition service. So actually, they usually in a minor eye condition service, NHS 111, GP practices, other optometrists do direct patients through into optical practice, and we worked very closely with those systems so that at a local level, patients would be signposted appropriately. It was very difficult to do that nationally. We did actually get involved in the national campaign that emphasised the role of primary care and the Help Us to Help You campaign, and through social media. But like I say, we had to be a little bit mindful that we have gaps in provision. We had areas of the country that actually weren't commissioned to deliver urgent eye care at a local level, and it wouldn't have been appropriate to bounce patients around in those areas. So unfortunately, we had to deliver a local solution.
Thanks, Zoe. I think that there's a question that's coming, which I think to some extent summarises quite a lot of the things that are going on at the moment in the question box. I'm going to go to Debbie on this one. I think what this is that can the sector have confidence in us and trust that we are able to make the correct case and have a genuine negotiation with either NHS England, or if we're talking about local services, CCG commissioners, to get the best outcome for the sector?
Absolutely. I think we've demonstrated being thrown together during COVID, and we have worked in the past before COVID hit, and we've worked well together on behalf of all our members. I think what we need to look at now is the lessons learned from COVID and explore options going forward to work jointly together, obviously going forward. And what committee or platform that we use to do that. I think I've seen in the question box that we've lost the Optical Confederation, but nobody in this team here was averse to working together. I think it was just down to logistics with all of that, and going forward we can review the opportunities available to come together when we have to and need to and want to.
I think that's right. Does anybody else want to make any comment on that? Harjit?
I think it's very healthy to be challenging about this, because we get FODA members all the time and I say, look, if not now, when? We have most of the country that has MECs and queues, and there's those areas where it's still not happening, even though all the conditions exist. Now, in this environment where we have decentralized commissioning and we have pushing out of the accountability to make these commissioning decisions, it is ever more challenging place to be. Now, that's why it's good to have an LOCs on the ground talking to those local commissioners to encourage them to change tact. But I do think that we as a sector really now have to really come together. A bit of a cliche, but really come together because of the conditions that patients really face. There will be long waiting lists in hospital for the foreseeable future. Even if we have a vaccine, glaucoma clinics will not recover. There is so much more we can do in primary care settings. We have the skills, the diagnostic equipment, and yet we have this very difficult place to navigate with NHS commissioning system, which has, on one hand, a bit, to be fair, has its own priorities and its own challenges, but on the other hand, simply it is too easy to duck the accountability of reducing avoidable sight loss. And you're right to challenge. We do have to work more. We do have to do more, but we are up against it because of the culture of NHS commissioning. Over to Peter.
Peter.
Thank you. So I just wanted to sort of lightly pick up on the national versus local point that was sort of at the beginning of the question, and I suspect a lot of people think, why have we gone local? And the truth of the matter is we asked for national. We pushed very, very, very hard for a national solution, and if I'm truthful, NHS England weren't opposed, but unfortunately the legislation and the commissioning pathways that are in place at the moment mean that even if they wanted to, it wasn't that easy to deliver it as a national solution. So it wasn't for a lack of trying or a lack of will. It was just in a very short period of time with the challenges that we had. There wasn't time to go back and rewrite legislation and change things. We had to work with what we'd got. And that was frustrating for everybody. But, the case was made. And I don't want people to think that we didn't sort of advance that argument, because obviously we see the same logic that postcode lotteries and different systems in different areas just aren't helpful for anyone.
Yeah, absolutely. I think that's a really important point to make, because we did have those discussions and we were very forceful in putting that forward. There's a great question coming, just to change tack, and I want to bring Daniel and Leslie into this. The BAME workforce and the links between COVID and, or the maybe not the links, but the links that have been published in some places between the BAME workforce and COVID may have led the BAME workforce to taking higher risks. The question asks whether or not we've got any thoughts around this. So to you, Daniel.
Yeah, no, that's a really good point. And so in June and July, NHS published a report which we had early sight of, and that set about a process, a stream of work to produce a risk assessment document. And actually, it's a document that I'm very proud to say that everyone here worked together on producing a sector-wide report, risk assessment document, which practitioners could use the same document in the whole of the UK to identify people at risk. BAME was one of the things, but it wasn't just that. Pregnancy, people living in households with shielded or at-risk people, and to make that individual risk assessment in the workplace happen, to ensure that anyone who felt they had a risk could be heard, and workplaces could make reasonable adjustments to support those practitioners or team members. And furthermore, NHS England then made it a compulsory, they had an audit which they're still completing every month to check, to enforce that all contractors are completing that at an individual level. So it's a very real concern, and the evidence base is, you know, it's still growing, it's still developing, we still don't understand this thing completely. But in the summer, when it was first alerted as a sector, we worked together to produce the risk assessment document and to ensure that that is happening to support practitioners in practice stay safe. I don't know if Leslie has anything to add.
Just to say that, you know, as I said at the outset, you keep the public safe by keeping practitioners safe, and therefore being really alert to where the risks to staff are is important, and we try to reinforce that through our business standards and the guidance that we've provided around that. And obviously the risk assessments are a really key component going forwards. And yes, I've been happy to be part of the conversations that we've had among sector groups of, you know, what does this mean and how can we address it. Still, you know, we still need more research and more, you know, we need to improve our level of understanding of how the effect is generated through combinations of lots of different factors. But I'm sure that, you know, like lots of other organisations on the call, you know, we're also thinking really hard about that for our own staff too.
Thanks, Leslie. And I think that segues quite nicely into what is very clearly the question of the moment, which is about vaccine. So there are two bits to this question. I'm going to split them into two and get the whole panel to make some comments on this. But I'm going to go back to Daniel in the first instance and ask whether or not there's any information or anything we can give the sector around whether or not we will be seen as a priority to receive vaccination.
Yeah, it's a very topical thing at the moment. Vaccines have been in the news a lot over the last 8 weeks, as now we've got I think 4 candidates in the final phase 3 trial, and the government has advance purchased over 100 million doses of 5 different vaccinations. So all of the sector groups here have been involved in conversations since August in this, and the government published a statement in early September, setting out their priority of who should receive vaccinations, and in the highest tier priority, people in care homes and care home staff, and then healthcare workers are listed, and we have all been, you know, lobbying and ensuring is very much the case that optometry is there with all other primary care workers to receive a vaccine. Optometrists are essential part of the frontline health force delivering eye care, saving sight, and therefore it is critical that they are up there with other healthcare professionals receiving the vaccination at that point in time. The conversation is still ongoing, and a lot of it is highly confidential, and we can't share exactly where we're at with that, but everyone here is part of that conversation, and we're working very hard to ensure that optometry is there with other primary care health professionals to receive that vaccination, to ensure that practitioners stay safe, but also that eye care stays open and practice teams stay healthy and able to deliver eye care for the next 6 months, year and a half, however long this may go on for.
Thank you, Daniel. And the second part of that question, which I'm going to address to Peter in the first instance, is about whether or not optical practices and optical practice teams could be involved in the administration of the vaccine.
Thanks, Richard. So as we understand it at the moment, the national direction is that these will be large sites, so not small primary care sites, so not optical practices delivering the vaccine, not small GP surgeries, not small pharmacies or anything like that. And that's for a couple of reasons, really. It's the throughput that's going to be needed, the volume that's going to be needed. And then there's the very specifics over how some of these vaccines are going to have to be stored and handled and all sorts, which we're not really geared up for. And then also on top of that, we've got the fact that we need to be delivering primary care. We need to be delivering eye care. And if we are not doing that, then we've got the problems that we've spoken about already, in that people are potentially losing their sight. So there is maybe the option, if people have capacity to volunteer to go and work at another site, that may well be an option. But as it stands, I don't think we're envisaging that practices themselves will be delivering vaccines.
Okay. Does anybody else want it? Debbie?
Yeah, just to add to Peter's point there with regards to individual optometrists and dispensing opticians, contact lens opticians, there is a link on the NHS website that was circulated yesterday, I think, by Abdo, and some others may have circulated it, where there is the opportunity for individuals to volunteer to work in these sites that Peter had mentioned there.
Thank you, Debbie. Right, there's a question that's come in, the most recent question about legislative change in order to allow for a national commissioning structure. I'm going to kind of almost not sidestep that, but what I am going to say is I think we're probably all aware that there is a potential legislative change within the next 2 years. It's been reported in the HSJ today about the changing in structures of CCGs and the alteration to CCG structure. And I'm assuming, my assumption would be that if there's any changes on that link with that, it will be knitted up in that legislative change that comes through. But it does lead to another question, which we've got submitted previously.
Sorry, Richard, is it possible just to come on the legislative programme? Just because it sort of links to the earlier point of people asking, what are we going to do locally? Just to be very clear, and it's what Peter said, it's so important that we preserve the National Sight Test Service, because once things tend to go local, they tend to get caught up in the budgets and be chopped and changed, and we end up with a postcode lottery that we're trying to avoid. There's nothing that any of us would like more than to achieve what this question asks, which praises the WEC system and the Scottish model and says, why can't we have a uniform service across England? Everybody on this call, I think, would very much like to get rid of the postcode lottery. The legislation that Richard has referred to is actually not going to promote a national approach to anything. What it's looking at doing is taking the 200 odd CCGs and making about 40 odd footprints. So in one sense, it might be a bit better than fragmented. It's too early to tell, but certainly there's no appetite within this legislative framework that we've seen that suggests there's any one in government that wants to do anything national. And I just think that's important to share. Sorry, Richard, back to you.
I think that's a fair point. I mean, what I was going to lead on to is one actually for Zoe, which was a pre-submitted question where there have been a number of CCGs that have engaged in a way they haven't done previously, and it's what we can do to, whilst we have the structures we have, what we can do to build on that engagement.
Thanks, Richard. Yes, so we are restricted to work within the commissioning landscape that we have available to us at the moment, and we have seen a change in appetite from commissioners and from systems as a whole, so integrated care systems, and they recognise there's a need to deliver eye care differently, but they also feel quite constrained by the commissioning landscape. I think the National Outpatient Transformation Programme is a real opportunity to make build on this change that we've seen recently and make the most of this appetite for delivering it differently. What we have seen is commissioners come together that have previously not wanted to commission extended primary care services from optical practices, that are now knocking on the door of optical practices and asking, actually, how are we going to be able to deliver this? So working together through the National Outpatient Transformation Programme, we can pull together our resources and deliver the systems, the tools to be able to do this. So we've got the CUES pathway and the CUES specification that describes how urgent care can be delivered in a COVID-safe way, in a more integrated way, using the whole of the primary care workforce and working together with the secondary care workforce. What we need to do is build on the principles of CUES, and that's what the newly published restoration pathways do. So we've got the restoration pathways. They are co-badged by all the stakeholders on the steering group, and so I think that really adds weight. So we're not moving forward, as an LOC talking just about primary care, but you're actually being able to go into a stakeholder meeting and say that these pathways, they're clinically endorsed by the College of Optometrists and Royal College of Ophthalmologists. They have the support of the whole of the optical sector, and RNIB and patient groups as well, getting it right first time teams, and the Clinical Council for Eye Health Commissioning. So I think because we're moving forward with one voice, and we've got a single offer to the system, I think we've got an opportunity to get these services commissioned in the coming months. And
do you think, Daniel, if I come in, just one question, I'll come in a minute. Do you think that would address what I think a number of people perceive or have seen to be the biggest issue, which is the hospitals being the barrier?
I think it will certainly help it move forward in the right direction, absolutely, because I think in the past there has been a perception that the hospitals have been the barrier, but we've got to remember that primary care and the hospital system have essentially been set up in competition. There's been this concept of having to decommission to recommission elsewhere. Now we're working more as a single system, and with shared outcomes for patients. And so there's been a bit behaviour change. So yes, I do think it will start moving in the right direction.
Daniel.
Yeah, I just want to very quickly underline Zoe's really important voice about coming at this with one voice, but a collection of organisations, because it picks up a couple of comments in there about why there's so many different organisations, what are you all doing differently? But actually, as a sector, we can be really strong with each of our own area of expertise, with a slightly different perspective and nuance is understood externally, but with one voice. So with the eye care transformation restoration, having both the Royal College of Ophthalmologists and ourselves endorse the clinical aspects of the pathway carries a certain weight and respect at a ministerial level. Having LOPSU's expertise with commissioning, delivering things on the ground, the systems and the processes in place carries the commissioning weight and trust. Having the support of the AOP, FODO, all of us together, we're bringing different things to the table, and that strengthens the case of the profession, which we simply wouldn't have if we were just one organisation that actually potentially was mistrusted by external organisations. I just really wanted to underline that really important point that most 99% of the time we share the same aspirations. We are one voice, but our different perspectives and nuances strengthen the profession. They strengthen our ability to be heard.
Great, thank you, Daniel. I'm glad we're recording this because that was really articulately put, and I can play it back in meetings now. So just linked to this, and something I want to bring Peter and Debbie in on. I think we're right to understand that there are risks involved with the outpatient project, but also to kind of embrace the opportunities. I'll go to Debbie first. Do you think we have the capacity in primary care to be able to capitalise?
I think we have the biggest majority of capacity, and where we don't have the capacity with regards to the infrastructure, then we have the optometrists and dispensing opticians who could work in the clinical hubs, for example. So yes, I do think we've definitely got the skill set and the capabilities to deliver the services, I think it will be down to, as Zoe said earlier, commissioning, infrastructure, etc. But yes, overall we do.
Brilliant. And Peter?
So I think we've lost sight of this a little bit in the transformation project, because we do have the capacity, but we've got so focused on COVID that we're saying, well, actually practices are really busy and they don't have capacity. But as we've just been speaking about, the vaccine or vaccines are on their way, and we can now see our way out of this. So talk about capacity and optometric practices is soon going to be back to where it was before, which means we most definitely then do have the capacity. We do have challenges around connectivity, and that's a huge one. And we keep making that point, because, I mean, Debbie just mentioned hubs. I'm not a fan of hubs. I've been quite vocal about that. I don't think they serve a purpose for optometry. We have a highly skilled, a highly trained and well-equipped workforce in community practice at very convenient locations that suit patients and mean avoiding journeys that potentially quite elderly people don't need to make. And moving people to hubs, for me, doesn't make any sense. We have the capacity, we have the skills, we just need to use it.
I've seen the steam coming out your ears there when I mentioned that, Peter. Just to clarify, I'm not a fan either, but in areas where we don't have that infrastructure, I think that's where we, and again, that's in the minority. Just to
it is. No, that's fine. I just think it's really important that we don't get caught up, because it doesn't help patients. And that's what this is about. It's about helping patients. And we've got all of these skills and all of this equipment and all this mass investment into practices, and we need to use it.
I absolutely agree with that. We've had a number of actually very specific questions coming in, which I think we'll pick up after the session in terms of grant payments. Sorry, that's my phone off. Can our panel talk about one of the questions that's coming is talking about the DNA rate, and whether or not, I'll go bring Harjit in on this and ask whether or not any work has been done with NHS England in order to mitigate the DNA rate that's occurring through track and trace.
Sorry, Richard, I missed that. The DNA rate going through track and trace? Or just the DNA of people cancelling because they've been, okay, sorry, I missed that. Okay, people cancelling. I think, look, there's two elements to this. One is the infection prevention control. If people are told to isolate at home, they're legally required to, and that's a good thing. Depending on the prevalence in any area at any one time, the cancellation rates are probably going to reflect a bit like if there's like any infectious disease, the cancellation rates are going to depend on the local prevalence of COVID-19. And we appreciate, in addition to that, that will sometimes be correlated with anxiety in that local population as well. Because if you have a higher infection rate, you have a more anxious local population. So other things being equal, you'll have cancellations both for those isolating because of family illness, their own illness, but also those just nervous of going out. We have brought this up with NHS England in terms of when we've been negotiating ongoing grant funding. But as of yet, the data hasn't shown, according to them, a universal drop-off. Now, there's reason to put some faith in that data, because the same trend's been reported in Wales as well, to say that actually activity is held up quite well on average. Now, there are those outlier cases. So again, if you have an outlier case, if you are noticing in a particular region that you're having lots of DNA rates, do let us know. One final thing on actually the test and trace thing, we are working again collectively behind the scenes to make sure the test and trace information is consistent across the country, especially to optometric practices. So that's another piece of work we're doing behind the scenes, the colleges, AOB, ABDO, NOC, FODO. So we are doing what we can to sort of get consistency. Peter put his hand up. Peter?
Yeah, Peter, do you want to come in?
Yeah, I was just going to say, I mean, I think the DNA rate's a really interesting thing, because, and we've made this point to NHS England, that larger businesses have greater capacity to flex what they do. So they may have been open 6 days, and now because they've got a large staff base, they may be open 7 days. They may be open, from 8 till 8 or whatever. So they've extended their hours. And the point we've made to NHS England is that doesn't necessarily reflect the smaller practices that may be more affected, because they don't have the workforce to do that. They don't have the staff to do that. So just taking this global number, which is what they tend to do, and say, well, look, numbers are good, isn't necessarily reflective of what's going sort of on in each region. So we are making that case, and we are monitoring it and sort of reinforcing it at every opportunity, because we are very aware that a global number doesn't necessarily represent the challenges that practices are facing.
Thanks, Peter. And Debbie, just whilst we're on this subject, in terms of how we're working with NHS England, I think there's a fear that in some areas there's a cliff edge, and we're suddenly, that at the moment we're working on a wave of pent-up demand, which at some point is going to disappear and demand is going to diminish. Is that something that we're discussing with NHS England, and actually do we think that's right?
Well, yes, we are in discussions again together with NHS England on this, and the bubble will burst if action isn't taken soon enough. So what more can you say on that? We're doing our best to represent the profession, utilise optical primary care to its full potential. We've put that argument across many a time. They have recognised, I think, the opportunities that are there. It's just about how they can make it work and roll it out. So I hope we don't get to that cliff edge, and fingers crossed we won't.
Harjit, you wanted to come in.
Yeah, I think it's something that sort of is in the back of all our minds. There's a few reasons to be assured, in the sense that capacity was so severely restricted, the bottleneck will build up as a long-term tail. So if you look at the numbers in that sense, the tail should last a bit longer, and hopefully as capacity resumes, most people will get to a reasonable level of sustainable activity, permitting the things that we already discussed. We actually monitor things such as government economic stimulus, because that public confidence to spend money, and not to bore you with economics, is key. So the furlough extension actually was probably more significant in terms of public confidence in going to an opticians to see and spend money on opticians than maybe the NHS grant in itself. So I would say, do keep an eye out. We do for you. We'll update you. But what the government's doing overall to ease the impact of the crisis is really critical in this cliff edge fear, because it won't be just demand, it'll be consumer confidence. Great.
Change tack a little bit. One for you again, Daniel, I'm afraid. And I think we've heard this in a number of different forums. As capacity is being constrained in hospitals, it's creating a bottleneck of placements for higher qualifications. Given where we're going to be with the outpatient transformation project, and notwithstanding, I think Peter's really, really important comments about really maximising core competency, are the college able to find different ways to deliver the qualifications?
Yeah, so that's a really good point, and I think actually probably my colleague in education is better qualified than me to answer it, and you could spend an hour thinking about the different nuances about it, because it's a workforce question, it's a core competencies question, and maximising. Optometrists are highly skilled professionals when they leave university and can offer a lot, but at the same time, like any healthcare professional, you have to develop your skills, you have to grow them. And the skills you need now, today, were different to the skills that optometrists had 10 years ago. And the skills that optometrists need in 10 years' time are very different. So there's a number of different issues there, but placements are an issue. And the higher qualifications, everyone who's worked very hard to get one, and they're recognised, they're highly regarded, the Royal College of Ophthalmologists really trust them, have been able to develop their scope of practice. And COVID has shown the potential of optometry in IP prescribing, in glaucoma care. Those clinicians with higher certs in glaucoma who can do gonioscopy are of real use to the secondary care services and delivering more care in primary care. But placements are this restriction. So is there scope for innovation in terms of using virtual placements? Is there scope for regulatory change in terms of IP placements being supervised by other IP optometrists? And really everything's on the table at the moment, and the college is listening, looking at workforce in particular. I know the GOC, I don't know if Leslie can come in with something about IP as well, are looking at ways that we can support more registrants to upskill with expertise, and COVID is really a diving board to leap off and actually show how much the profession can work. And part of that, Peter is absolutely right, is based on being confident in our core competency when we leave university and what we can do without anything extra. But at the same time, that's got to be partnered with skills, very specific skills like IP, like gonioscopy, which aren't core competency at the moment, and are needed to deliver a wide range of services.
So Leslie.
Yeah, I'd love to come in on that, because as I said right at the outset, that looking forward, it is our education reforms that we think are really core in terms of responding to COVID, because when we set off the ESR, Education Strategic Review, it was all about trying to update our skills and education in order for the workforce of tomorrow. But the future has accelerated towards us incredibly as a result of COVID. So our initial focus has been on initial education and training, undergraduate programs, and entry to the register. We're doing some great work with the our education advisory groups, again involving the parties who are in this call, and that we have just very recently kicked off kind of phase 2, if you like, which is to look at IP and CLOs, etc., as well as our core entry level qualifications. So I think that's really important. And I just want to say something about the cliff edge, because the cliff edge in terms of traditional work, pent-up demand, etc., may be coming some point down the track, but the demand for eye care services in its entirety is growing and growing, and the backlog that there is in secondary care and the potential to pull that through into primary care is just huge. But we have got to get the education and training to line up with the demand that we have for the future. And I feel as if there's definitely catch up to do. It's no longer about the future, it is about now.
Yeah, absolutely. And I think actually, and given the time, this will almost certainly be the last question. That leads to a question for everybody, or rather the panel collectively, and it's very similar to the question we asked last night about where do we think we are going to be. So in given what we know, given where we hope we're moving towards, if we were to reconvene this panel in 2 years' time, what do you think should be the top 3 ambitions now that we can say we've been able to hopefully deliver? Always difficult to pick on somebody, so I'm going to go to Peter first.
Thanks. So I think we want to see optometry embedded as the place you go when you have an eye problem, without any shadow of a doubt. That has to be, none of this, well, do I go to the GP? Do I go here? Optometry practices and our DO colleagues as well. But obviously, what we offer will vary very slightly there. We need to see far more of the things that have traditionally been hospital-based delivered in primary care. And they need to be delivered just routinely. And then we need to see that those connections to enable that transfer of information are all absolutely in place, so that if it is outside of your competence, you can easily share information to somebody, get advice, get guidance, pass the referral on safely and securely to somebody else, to make certain that there are no gaps in the journey for the patient. And I think if we've got those 3 things, a recognition of where we need to be, a enhancement of what we currently offer, and those connections in place, and I think we'll be in a lot better place.
So I'm sure everybody's going to pretty much come up with the same thing. Has anybody got anything they want to add to that list of outputs?
I would just say that in November 22, my hope and expectation is that we will be in the throes of approving new programs of learning for optometry and for dispensing opticians as well, ready for launch in September 23. And they will be exciting, really exciting new courses that have clinical practice right at the heart, that are properly integrated in teaching, learning and assessment. And I think that will be a significant landmark in the development of the professions, of both professions.
I would just add, carry on, Daniel.
Sorry, just one point. In our 5-year strategic plan, one of our ambitions, and it's a very big ambition, is that the college will become a Royal College of Optometrists. And I've got no idea whether that will be possible or not. It's quite an ambition. But regardless of the title, I hope that optometrists are as respected as GPs and ophthalmologists and are delivering that care, as Peter mentioned. They are the essential go-to person that every citizen looks to for preventative eye care and for when they've got a problem. And on a final point, there's that famous saying that sometimes there's decades when there's no change, and then there's months when there's decades of change. And I've been highly frustrated that since 2009, 2010, really nothing has happened. You've had IP practitioners in 2009, you had OCTs in 2009, and things have been lingering on for quite a long time. And now over the last 9 months, there has been significant transformative change in how we deliver care. And I think we're in a position where actually we can carry on that momentum and really transform the way eye care is delivered to citizens across the UK.
Zoe, you want to come in?
Yeah, just to pick up on Daniel's comment there, that we've all been living and feeling the frustration, haven't we? And if we'd sat here without COVID, we'd been having a conversation saying, well, we've improved the feedback from ophthalmology to primary care, we'd have all been sitting really delighted. Now that's just not going to be enough. We need, as Peter says, we need connectivity. We need advice and guidance. So when that patient sitting is in your chair in primary care, actually you can really broaden the scope of care that you can deliver, because you can pull in the expertise from secondary care colleagues without the patient having to go into the hospital. You can draw on the expertise across your network of optical practices and your colleague sitting in another practice that has got an independent prescribing qualification or another higher qualification, or a specialist interest in low vision, whatever it might be. We just need to get more joined up, and I think that the technology is the key to that, isn't it, to get us all connected.
Archie.
I just think that if 2 years from now, nobody in this country should be going blind because they're waiting for a follow-up to glaucoma. And if we work backwards from that, we get everything that we've been talking about in the summary about optometrists being seen as peers and dispensing opticians being fully utilized, and CLOs and primary eye care infrastructure and IT, and all that stuff flows from a common goal, which ophthalmology and primary eye care can all come around. There's no reason 2 years from now anyone should be going blind because of glaucoma, because one thing that also hasn't changed, we've had 2 serious incident reports on people losing their vision, and all, as of today, all the conditions are there for that to get worse unless we do something about it, and we can do something about it. We should. So in 2 years from now, if we shouldn't see, and that will solve a lot of other problems. So that's mine.
Brilliant. I think on that note, we will end the discussion now. I think as with last night, this is a debate that could have gone on significantly longer, but I hope that actually what this really is a continuation of a debate that's been happening, and a debate that will continue. So thank you to every single one of our panelists. In closing this, there's a couple of comments I wanted to make. The first one is to say that I hope that what's come across here is that we are working in a coordinated way, and that's we in a royal sense. It's the bodies working with LOCs, working with practices, working with individuals, and there is and has been a common aim in what absolutely everybody has been trying to do, which is to maintain the services for the patients and to ensure that there is no patient comes to any unnecessary harm because of the pandemic, if we were able to avoid that. And I think that for me is the key thing that comes through from this. And I really hope that we're able to continue the partnership that's been forged out of COVID to drive everything forward as we move on over the next, pulling out of the pandemic, albeit we're nowhere near that, and we start to move towards the restoration of services that we learned about last night. So thank you again to the panel. Thank you again to our sponsor for the evening, which was Optus. There will be, coming up on the screen in a minute, a feedback survey, as if by magic it pops up. I'd really appreciate if people could complete this, because it helps us to evaluate the session, but it also helps us to plan future sessions. One of the learnings for me is going to be ban your family from ringing you in the middle of a session because you can hear the phone going off. But such are the delights of working at home. So thank you to absolutely everybody who's attended and taken part and submitted questions. We have recorded all the questions, so we will go back through them as last night, and anything that we need to clarify or any questions that haven't been answered, we can do that. As I said in my introduction, this session will be hosted on a channel, and we'll send the links through so that people can re-watch or can forward that to their colleagues who've not been able to attend. This really ends this week's sessions for the NOC, but it doesn't end the NOC. It continues into next week. So if people want to book sessions for next week, the booking's still open. The peer discussion sessions that are taking place with WOPEC are just about full. The first session is pretty much booked. I think there's a couple of spaces left. There are some spaces left on the second session. So if people want to get involved in that, I really urge you to go and book now. But I really hope going into second week, we can take forward the discussions we've had so far and really build a solid direction for us to move in the future. So thank you to everybody and good night.